Tonight's webinar is all about wound pain, which is such an important topic. I think all of us out there that have been managing patients with wounds will at some point have come across a complex case, or a case where getting pain under control is really difficult. Pain impacts massively, doesn't it, on someone's quality of life, but also, you know, we hear a lot about people not being able to tolerate treatment plans because pain is a significant symptom, and that ultimately will lead to non-healing wounds. So we need to get better at being able to manage pain. You know, there's lots of strategies out there, and tonight's webinar will help you understand pain and also looking at strategies for managing that, and there is a solution for that. So this has been run by the Society of Tissue Viability, but we are delighted to have this event sponsored by AccelHeal, and we're really appreciative of them investing their time in this tonight. So before we start, we have some polling questions. Oh, and before I go any further, I just want to really just talk about how things are going to run today. So we're going to have our main speaker talking about pain, and then we've got an experienced tissue viability nurse who's going to share her stories with you, and the impact of pain on her patients and how she went about resolving some of these problems. The first question is, how many patients with wound-related pain problems do you see in your daily practice? Is that 1 to 2, 3 to 5, 6 to 10, or more than 10? If you could just click on what your answer is there, please. Okay, so here we go. So the majority are 3 to 5. So, you know, that's in daily practice. So it's still quite a few, isn't it, really, followed by 1 to 2. So thanks for that. Okay, so we'll close that one and go on to the second question. How confident do you feel about pain management? Not confident at all, some confidence, confident, or very confident? If you could just vote now what your answer is, please. Okay, so some confidence. So still there's room there, isn't there, for additional knowledge and skills to try and build on sort of how you help manage patients with their wound-related pain. So the majority is some confidence, but yeah. No one is saying they're very confident. So there's a lot to be learned still about this, because I think it is such a complex topic, isn't it? Thanks for that. So we'll have the third question, please. So what options are available for you for pain management in your practice? So referral to GP or a nurse prescriber for prescribed drugs, referral to pain team, alternative therapies, combination of the above, or none of the above? Okay, so the majority is a referral to a GP or a prescriber, a nurse prescriber for prescribed drugs. And that doesn't surprise me, really. Referral to the pain team, 38%. That's quite reassuring, because I know some areas haven't got pain teams. Alternative therapies is quite low, combination, and 3% none of the above. Okay, so yeah, right. And the final question, in your experience, it'll come up in a minute, how often is pain a reason for no compression therapy or reduced compression? Never, occasionally, or regularly? Okay, so occasionally or regularly. So that's an interesting one, because certainly, you know, when we get referrals into, say, tissue viability, that's often being cited. Pain is a reason why people can't tolerate compression. So the majority is occasionally or regularly. So thanks for that. That can be closed. So I am now going to hand over to our first speaker, who's spoken for the Society of Tissue Viability before, extremely knowledgeable, Amelia Swift. And Amelia is a reader in health professional education and head of education at the Institute of Clinical Services at the University of Birmingham. And so over to you, Amelia. Thank you very much.
Thank you very much, Sarah. Can you hear me okay?
Yes, fine.
Fantastic. I was very late and I apologise. I've had horrendous technical problems, so I'm going to get straight into it now. So I'm going to talk to you about management of wound pain, and we're going to talk about what the different types of wound pains are that we might come across and how pain is best managed. But I've got a slightly different take on things today, and I hope that it's going to be useful to you. So we generally think about pain and categorize pain in order to talk about it, in order to make decisions about how best to treat it. And we tend to divide pain into three main types according to the mechanism that is responsible for that pain. So we have nociceptive pain, which is the pain that is detected by nociceptors, which are those specialist sensory receptors spread throughout the tissues to detect chemical, thermal, mechanical, noxious stimuli, potentially harmful stimuli. The second type of pain that we can use as categorizing is neuropathic pain, which is pain caused by damage to or dysfunction of the nervous system. So this is the sort of pain that's responsible for diabetic neuropathy, for example. And then a third type of pain, which is a relatively recent player on the team, and this is nociplastic pain. And nociplastic pain is a new term that's been coined to capture those pains that don't really fit into the other. It tends to be pain that arises from within the nociceptive system itself. So the pain system's been working fine, and then something has changed. There's been a neuroplastic change, and now all of a sudden we've got continuing pain, despite usually the absence of a stimulus. So we're going to focus predominantly on nociceptive pain for this short session this evening. And I'm going to use a case study to illustrate nociceptive pain. And my case study is going to be Alice, who's a 50-year-old lady who was admitted to the intensive care unit following an accidental overdose of paracetamol. And she was treated in intensive care for several weeks. And she spent some of that time under medical paralysis and sedation. And during that time, she developed a stage 2 pressure ulcer on her sacrum. And while she's recovering well now, she still needs some support with this wound healing. So that's just setting the scene. And I've chosen this stage 2 pressure ulcer because it's a fairly good approximation of all sorts of difficult wounds that we might come across. So the first thing to reiterate, or the first thing to get clear, is that pain management is all about interrupting pain signaling in some fashion. It doesn't really matter what type of pain that is. The more we understand about pain physiology, the easier it will be to interrupt those pain signals as they're transmitted across the body. So that's the basic principle. Now, pain as a construct, the sort of phenomenon of pain, doesn't actually exist until pain has actually entered our brain and our consciousness. Prior to that, it's nociception. It's simply the detection of noxious stimuli by this great big array of specialist sensory nerves called nociceptors. And the picture on the screen at the moment is showing us a pin sticking into a finger, and this represents...
Sorry, Amelia, can I
Hello.
interrupt? Because we're not seeing your slides at the moment.
Well, that's really helpful, isn't it? I'll just put those on.
Thank you.
Okay, it should help from now on then. So I'm just going to pop back, and there's Alice, and we've got the picture of the stage 2 pressure ulcer. And moving on then, I'm talking about a pain pathway, and the fact that pain doesn't really exist until it reaches the brain and our consciousness. And what you can see now on this picture is a nail or a pin sticking into somebody's finger, creating a harmful stimulus. And this harmful stimulus is being detected by a specialist sensory fiber called a nociceptor. This type of stimulus is being detected by something called an A delta receptor. And that A delta receptor is going to transduce or change that noxious stimulus into an action potential and carry that signal along the length of the nociceptor into the dorsal horn of the spinal cord, which you can see down in the bottom of the picture. And in the dorsal horn of the spinal cord, you're going to have some modulation happening. And modulation is either going to enhance the amount of pain or amplify the amount of pain that you're experiencing, or inhibit the amount of pain you're experiencing. And after modulation, the signal carries on upwards into the brain, and this signal interacts with multiple different sensors in the brain, including the brain stem, the amygdala, the somatosensory cortex, and the frontal lobes. And each of those different areas of the brain is responsible for a quality of pain that we are used to experiencing. So our somatosensory cortex will tell us where the pain is, and our amygdala and limbic system will stimulate an emotional response to the pain, and also either some amplification or some inhibition of that pain. And then, of course, we reach into our memory and start associating our pain with past experiences, and we start thinking about the pain, what it might be, what it might mean to us. And that creates this experience of pain as a whole, a holistic experience rather than just a pure sensory experience. So Alice is going to have nociceptive pain from that wound, and the chemical mediators created as part of the inflammatory process in that wound are the pin in this situation. So we're going to go a bit deeper and have a look at what's going on in the tissues for Alice. So this picture, taken from Janakiram et al., is a kind of overview of some of the inflammatory responses that happens across the process of wound healing through inflammation, proliferation, etc. So we've got some of the major chemical mediators displayed here, such as prostaglandins, interleukins, interferons, TNF alpha, and so on. Now, these chemicals that are produced as a result of tissue injury are responsible for communication and coordination of the immune response. And in initial stages, in that acute inflammatory stage, they're primarily responsible for destruction of pathogens, for cleaning up the wound and creating a situation in which good wound healing can take place. But they're also responsible for initiating pain from that wound. So the same chemicals responsible for two different functions. So in the picture on the left here, we can see a number of different immune cells which are producing all of these different chemical mediators. And each of those chemical mediators has a corresponding receptor on the sensory nerve ending, which you can see on the right of the left-hand picture. So, for example, we've got hydrogen ions, which are interacting with ASIC receptors. We've got adenosine triphosphate, which is interacting with P2X3 receptors. And one of my favorites, we've got capsaicin or heat, which is interacting with the TRPV1 receptor. And I like the TRPV1 receptor because it's the thing that makes eating chili peppers feel hot. And it's the same receptor that responds to extreme heat. So that's why chilies feel hot. I don't know why that tickles me, but it always does. And it also interests me that squirrels have chili receptors, but birds don't. So you can always stop your birds eating your squirrels eating your bird seed by popping a load of chili seeds in. So we've got all of these chemical mediators being produced, and each one has a corresponding receptor on that nociceptor. And what's going to happen is the more of these chemicals you've got in the area, the more of those receptors are going to be stimulated. And each receptor that's stimulated allows some sodium into the cell or causes the release of some calcium from within the nerve cell. And that increases the positive charge within the cell. You can see the picture on the right looking at the action potential. We increase the positive charge until it reaches a certain threshold, and that causes an action potential to be generated, which of course sends a signal along the axon towards the dorsal horn of the spinal cord and then upwards to the brain. So this is the whole reason why inflammation and tissue injury causes pain, because we've got these chemicals which are having two purposes. Now, one of the important things to note about this wound pain for our purposes is today is that when you initiate pain in this way, it isn't a simple one-way communication. When this nociceptor is triggered in this way to create an action potential, it also releases chemicals back into the extracellular fluid. And a couple of the chemicals that it releases are called substance P and calcitonin gene-related peptide, or CGRP. And these two neuropeptides are responsible for triggering further release of chemical mediators in the area. So they interact with mast cells and other cells to trigger further release of chemicals. And they also make this nerve fiber more sensitive and more easy to trigger by those chemicals that are already in the area. So it's kind of making everything on a hair trigger. Now, that's really useful from an evolutionary perspective because it makes the wound bed and the immediate area around the wound bed exquisitely painful, and that means that you can't touch it, which means that you protect it. And we'll come back to this idea in a little while. Now, this type of pain, this nociceptive pain, is actually quite amenable to a couple of, or 2 or 3 different classes of pain relieving drugs that we use commonly. We've got the anti-inflammatory drugs. So along the top of this picture, we've got a sort of diagrammatic representation of a pain pathway. On the left-hand side, we've got a nociceptive nerve ending waiting to be stimulated. And then that signal is going to travel across from left to right all the way over to the brain. And it's when the signal reaches the brain that we can sense pain. So one of the main protagonists in this inflammatory soup are the prostaglandins. And prostaglandins are produced from broken down cell walls and phospholipids that are floating around in that chemical soup. And the prostaglandins are really, really good at sensitizing that nociceptive nerve ending and making it more likely to fire. So if we can reduce the activity of those prostaglandins by using anti-inflammatory drugs which prevent its production, then we can reduce the sensitization, and then we can make it less likely that those nociceptors will fire. Interestingly, prostaglandins are also released as part of an amplification process for pain that's going on in the dorsal horn. So when you're using your anti-inflammatory drugs, they're acting there at the periphery to reduce sensitization, but they're also acting in the dorsal horn of the spinal cord as well. Now, that's great, and these drugs are really fantastic at managing acute pain, like early wound pain. But the NSAIDs also have an impact on the COX-1, which is responsible for producing or responsible for coordinating other aspects of prostaglandins, which is making sure that we've got good renal function, regulating platelets and certain parts of blood clotting, and making sure we produce enough mucus in our stomachs. So getting rid of prostaglandin can also lead to an increase in these side effects, and we need to be cautious for people who are at risk of that. But there are also concerns that anti-inflammatories, through their action on prostaglandins, slow down bone healing. And what's more concerning to us in terms of Alice's wound is that there is some suggestion that using prostaglandins in a wound that is beginning to become of that hard to heal type is going to actually stop the wound switching over from that early inflammatory phase to the proliferative phase. So I'm going to come back to that in just a second. So then we have the opioids. Opioids are another class of drugs which are extremely useful for acute short-term pain, and unfortunately become progressively less useful the longer a person has pain or the more complex a person's pain becomes. And if we look at the action potential picture on the bottom right of the screen here, I can show you how the opioids work. So an action potential is produced because there's an increase in this positive charge in the neuron, and that reaches a certain threshold, which then sends a signal shooting off up to the dorsal horn and to the brain. After that action potential is gone, then the neuron becomes refractory for a short while everything resets, and this period of hyperpolarization where it can't actually be initiated. When opioids work by increasing that hyperpolarization, they actually make these neurons less likely to fire. So really good at controlling pain because of the way that they work. And they work all over the body, a little bit in the tissues in the periphery, but predominantly in the dorsal horn of the spinal cord and in the brain itself, reducing pain that way. So that sounds fantastic. That's going to have a positive effect on somebody like Alice. They also prevent the release of substance P and CGRP, which I mentioned a little while ago. And those are those neuropeptides that are released from the nociceptor in response to us sensing pain. And so they reduce that, and therefore they reduce the amount of sensitization of the pain system. And that's absolutely brilliant. However, we'll come on to a problem in a little while, because obviously having one positive effect usually is balanced out by that same thing being negative in another way. And we'll come back to that in a second. I'm just checking if I'm going to talk about it here, actually. No, I'm going to talk about it here. So the thing about substance P and CGRP is they are also required for switching the wound from that pro-inflammatory state to the proliferative state. And so there's been a lot of studies that have suggested that when you've got one of these wounds that's sitting on that cusp of hard to heal, there's an actual reduction in the speed of wound healing. And the more morphine somebody's on, the less likely it is that that wound will heal well. And that's because it's not switching effectively between acute inflammation and proliferation. So swings and roundabouts with these two drugs, both very effective for pain management, but in those complex wounds and in people with risk factors, they become less and less useful. There is a good news story, and that's local anaesthetics. They don't seem to have any impact on wound healing. Hurrah. A little bit more tricky to use, unfortunately. They predominantly work in the periphery, reducing the amount of action potentials that are created. They can be directly applied to wounds, and they can be very effective. And this bottom right-hand picture of the graph shows us that using local anaesthetic into wounds doesn't stop the wound reducing in width, doesn't stop the wound contracting in terms of its length. But our biggest challenge, I think, is not in those acute wounds. It's in making sure that wounds actually continue through the healing process. So our problem is when a wound doesn't move on from acute inflammation. And lots of things can make that happen. So infection, poor nutrition, re-traumatizing, all sorts of things can have an impact on stopping that acute inflammatory process from coming to an end. But some of the things that can stop this transition from acute inflammation into proliferation are the use of some of our pain drugs. So, for example, our opioids. Keratinocytes have mu receptors on them, and they respond to the opioid drugs. Keratinocytes produce transforming growth factor beta and lots of other things. And TGF beta, or transforming growth factor beta, fantastic for helping epithelialization at the margins of chronic wounds, which makes you think, good, that morphine could be really effective. But unfortunately, opioids also interfere with immune activation, tissue oxygenation, and angiogenesis. So you've got a balancing act going on there. In many cases, it won't make a clinical difference to a patient. But one of the largest studies looking at opioids in wound healing, the We Heal study, which was published in 2017, showed that increasing amounts of opioid doses did actually prevent wounds from healing so well as they might do in comparison to wounds where people weren't taking opioids. And I mentioned before, we've got our prostaglandins, and the prostaglandins are really important in helping macrophages switch from one function to another function. So at the early start of wound healing, we've got a predomination of these macrophages called M1 macrophages, which are largely pro-inflammatory and drive all of that cleaning up process. But in the proliferative phase, we need more M2 macrophages, which are anti-inflammatory and pro-regenerative. And the switch from M1 to M2 is driven by a quite complex series of events, but a couple of things that are involved in that, or one of the things that's involved in that, is prostaglandin E2, which of course we suppress when we use anti-inflammatories. So we're stuck with a bit of a problem. People with hard to heal wounds do experience an awful lot of pain. I don't know why I've got 50 to 50% of patients. It isn't exactly 50% of patients. I've clearly made a mistake there. But up to 50% of patients experience pain. In arterial ulcers, the amount of patients is even higher than that. And what's really interesting is that a lot of patients have mixed pain. So they have the nociceptive pain that we're talking about, but they also have neuropathic pain. And I just want to briefly mention management of neuropathic pain. So neuropathic pain doesn't respond well to opioids and anti-inflammatories. It tends to respond better to anticonvulsants and antidepressants, which work at different parts of that pain pathway. And there was a really nice consensus study done by David Nutt and a group of experts in pain and wound healing and cannabinoids and psychiatrists and neurologists and all sorts of people. And this consensus group included patients as well. And what they said was, okay, we've got neuropathic pain. What sort of treatments do you think are most effective for neuropathic pain? To this huge, great big group of a variety of experts. And they came up with this list on the left-hand side of this picture here, where the higher the score is, the more useful that they thought this treatment would be. So the top three that came out were duloxetine and amitriptyline, the antidepressants, and gabapentinoids. So no big surprises there. But what was interesting was the emphasis that they put on cannabinoids, THC, CBD, those kind of things. And they felt that cannabinoids were far more useful in the management of neuropathic pain than the clinical research was leading us to believe. And they wanted to really focus a bit more on that. And if you talk to patients, you find that they also feel that they should have better access to cannabinoids because they find them more useful than the randomized controlled trials will suggest. So maybe that's a potential treatment that we should be exploring in wound management. But the problem with drugs for neuropathic pain is that they all tend to make you a bit foggy. The older you are, the more cognitive impairment you can experience from them. They don't leave you feeling great. And that can be a bit of a problem, particularly if you've got a patient who has poor mobility or is at risk of falls. So there are some limitations on these drugs. If a patient is responding to them, that's absolutely great. So we're running out of options, unfortunately, but pain is a really serious issue for many patients with wounds. And if we look at the picture on the left here, we've got a study which is showing us sort of median pain. The little dashes in these boxes are the median pain that people with a variety of different wounds were experiencing. And it's in around about the 50 out of 100 area for an average sort of pain that people are feeling. And the impact of pain on a person is all-encompassing. So people talk about feeling like they've lost themselves. They feel hopeless and helpless. They feel isolated. They can't sleep. It's having this huge, absolutely huge impact. And so it's really important that we try and find something that's helping. And it's also important, I like the question that was asked at the beginning, how many of you are able to get your patients into full compression? And this study by Briggs and Kloss in 2006, quite a while ago now, 44% of patients weren't able to tolerate full compression. And Leanne and Robin asked at a conference recently in 2020, does a patient having bad pain stop you from putting them in full compression? And quite a few nurses said, yes, it did. But if we can get patients onto the track of healing, onto the pathway of healing, this graph on the right shows that within a couple of days, the pain drops off absolutely dramatically as we initiate healing. So it's worth going through that barrier. Now, what I'm going to suggest next is that we start paying a lot more attention to electrical stimulation therapy. I've talked quite a lot about the limitations of our pharmacy that we've got available for us in wound pain management, particularly in chronic wound pain management. The cost of poorly treated wounds is absolutely astronomical, £8.3 billion a year managing unhealed wounds. And this is data taken from 2017. And we know that we are increasing the number of patients that are going to have chronic poorly healing wounds as time goes on. So this is a low estimate at the moment. Now, electrical stimulation therapy offers a completely different approach to this, and it takes advantage of the fact that we have a natural electrical potential across our skin. So within the deeper tissues, we're positive, and the surface of the skin, we're more negative. And there's this constant movement of ions around keeping that electrical potential going. And that electrical potential is really important for orientating cells, for communicating, for drawing things into the environment, for keeping homeostasis going, essentially. And when we have a wound, that electrical potential is disrupted and the center of the wound becomes the negative center. And that's a really helpful thing because it starts drawing the electrical current. Instead of going up and round, the electrical current is going into the center of the wound, and it's bringing with it all of the different chemicals and cell types that are needed to stimulate healing. And in a chronic wound, this is less likely to happen, particularly if your wound bed is dry, if you've got lots of problems. So you need a relatively healthy wound for this electrical current to actually stimulate healing. And I've got a picture of Robin Martin on the right here, because if you go to the AccelHeal website, there's a really good video there talking a little bit more about this electrical stimulation therapy and about how it works. So I'd encourage you to go and have a look at that. And I've got some pictures here of nurses putting an AccelHeal device, an AccelHeal Solo, onto a patient's wound. And what this is going to do is it's going to re-establish that electrical current across the wound. And that's going to it does have a fairly dramatic effect on the speed of healing. And it's portable, and it's reassuring to the patient because they can see it's working because it's got a little flashing green light. You can see it's not working because the orange light comes on. So it's all good. It doesn't interfere with wound healing. It enhances it, speeds it up. But from my perspective, one of the best things about the AccelHeal device, quite apart from the fact it's stimulating healing, is it's also reducing pain. So you don't need to look at studies that are only about the AccelHeal device to see this. There are a host of meta-analyses and other studies which are showing us that the use of electrical stimulation in chronic wounds, in venous leg ulcers, in diabetic ulcers, actually reduces pain by a significant amount. And this is one of the meta-analyses. And if you have my slide set, I've listed 7 or 8 different meta-analyses it's worth having a look at. And what these meta-analyses are showing us is that electrical stimulation not only reduces pain fairly dramatically and rapidly, almost as soon as you put it on, but you're getting a reduction of wound surface area, an increased rate of healing. The improvement seems bigger in chronic wounds than it does in acute wounds. And importantly, it's not going to cost, because it's costing the same amount as standard care, because you're getting this more rapid healing process. And I'm just going to talk about Liz, because I know she's on the call. Liz has done a couple of really nice studies evaluating this AccelHeal device and looking at how quickly you're getting pain relief. As soon as you start putting that device on, you're getting a massive reduction in pain. So Liz is saying that within a couple of weeks, the pain is, so we're starting off with pain, a pain reduction of 84% within a couple of weeks of treatment, with a mean pain score of 0.7 on the VAS. So we are seeing fairly rapid and sustained reductions in pain, as well as increases in healing. And the two they go together, because healing does reduce pain, but you're kind of getting more of an effect than that. And I'm still, one of the reasons I'm still interested in working with AccelHeal is still trying to figure out exactly how that's going on. Now, it's another study by Nair et al., who's looking at chronic wound response. And one of the reasons that I've put this in is because this Nair study tells us that even when a wound isn't in optimal condition, even when it's not a clean wound bed, you're getting a significant increase rate of healing and a reduction of pain. So at baseline, they've got a mean pain of 6.75 out of 10, and 7 out of 10 patients had pain greater than 6 out of 10. By the end of the first week, wound pain was down to 3.4 out of 10, and it continued to decline after that. And at the final assessment, there were 4 out of 10 patients who didn't have any pain at all, and they'd stopped using their medications. So, their pain medications. So I think that it's really worth investigating this as a standard therapy. This isn't adjunct. This is something we should be just using more of. So my final couple of slides. I'm not a salesperson for AccelHeal, but I am a salesperson for electrical stimulation, because what I've said to you today is that there are severe limitations in our pharmaceutical armory for wound pain. It's bothered me all the way through my nursing career that we just can't manage this pain effectively. And for those patients who are troubled by pain, then we can increase compliance with treatment, we can increase healing, and we can increase quality of life, and we can decrease pain. And we're doing that with no side effects. So my overall summary was, yes, be aggressive in your pain management, but you know from your experience that you have some limitations with pharmacological therapies because of side effects, contraindications. Sometimes, especially in chronic wounds, you're not getting an awful lot of pain reduction despite using optimal treatment. And some of these therapies, the NSAIDs and the opioids, are actually having a detrimental effect on the healing of hard-to-heal wounds in particular. We know that pain has a big impact on the patient, but I think, and we are beginning to see a lot of evidence in support of this, that electrical stimulation therapy is improving our armory absolutely dramatically. And that's all from me. Thank you.
Thanks very much, Amelia. That was absolutely fascinating. And I was particularly picked up on the about bone healing. Just thinking about my mother who fractured her pelvis, and she was taking a lot of, or the association with ibuprofen, who was taking a lot of that when possibly she shouldn't have been. And in fact, she hasn't had a lot of good bone growth over one particular fracture, but we'll come on to that at the questions at the end. That was fascinating. So I'm now quickly going to move on because we started a bit late, folks. I hope you'll be able to stay with us because I can see loads of questions coming through and we do want to have those answered the best we can. So we are probably going to run a little bit late, but I'm absolutely sure it is be worth it. So I'd like now to introduce Liz Oven, who is an independent tissue viability nurse, who's going to be sharing some of her experience of using this technology and the impact it's had on patients. Thanks very much, Liz.
Thank you, Sarah. Good evening, everyone. Thank you very much to Amelia for a very enlightening and interesting presentation. I've actually been using AccelHeal for 11 years now, and I've had some excellent results both in pain reduction and in wound healing. And I've used it in a wide variety of wounds, venous leg ulcers, arterial, mixed etiology, pressure ulcers, surgical wounds. And had, as I say, a very, very good success rate, both with healing and pain. And in my experience over the years, I've really noted this very rapid reduction in wound pain. I've even seen it within a few hours, but certainly within the first 3 to 4 days is sort of what's typically seen. And that pain then continues to reduce both during the therapy and following on from the therapy. So I'm absolutely delighted to share with you now a recent case study of a patient suffering with a very, very painful leg ulcer. It was a venous leg ulcer, and the impact that AccelHeal Solo actually had on her improvements to her quality of life. As Amelia has alluded to in her presentation, pain often dominates these patients' lives and limits their functioning. So June presented to the Hearts 1 GP Federation leg clinic with a venous leg ulcer which had been present for 8 weeks. Hearts 1 GP Federation have actually implemented an AccelHeal Solo pathway for painful and or non-healing venous leg ulcers and mixed etiology ulcers. So I was introduced to June whilst providing support and training for the team to use the device. And she had a history of previous ulceration 5 years previously, which had taken over 18 months to heal. The wound recurred following a very minor traumatic injury. And she had been visiting the practice nurse prior to seeing the specialist team. And the pain had become so intense that she actually had fainted during dressing changes, despite taking regular analgesics, including opioids. So in this first short video, June describes the experiences of living with a painful venous leg ulcer. And June, whilst camera shy, she was very, very keen to share her story. So Kerry, could you play the first video, please?
My ulcer was very, very painful, so painful that I just didn't know what to do with myself. I was taking medication, paracetamols, but they just didn't touch the pain. And so I went to the doctors and I got some Oromorph. Oromorph did help a lot, but I didn't want to get too used to having the Oromorph. Because I'm on my own, I found things very difficult to do. Standing was not, the worst thing really. I'm trying to do my own cleaning in the flat, and I wasn't able to go out shopping unless I used a taxi, which of course using that all the time is very expensive. And that's about it really. I just couldn't do anything. I couldn't do my gardening, which I love to do. I just couldn't face doing anything. I just laid on my bed. I wasn't sleeping on a night. And that is why during the day I tried to get some rest. But I didn't get very much rest at all for weeks. I got quite worried about myself because having just gone through a bereavement, I was in a bad way to start with. So when the ulcer started, I was just no good. I was in a mess.
So following the team's review, they decided to apply the AccelHeal Solo with the aim of reducing the pain to avoid excessive analgesia usage and also to expedite wound healing. So let me now play the next video where June actually shares her thoughts about using the therapy and having it applied, and the pronounced effect this actually had on reducing her pain and improving her quality of life. Her pain score actually reduced from 9 out of 10 to 3 out of 10 on the VAS score within 3 weeks. So Kerry, could you play the next video, please?
The device sounded quite exciting, but I'd never heard of it before. When I first had the device fitted, yes, I did wonder what it would be like. Would it be uncomfortable? It was quite comfortable for me. You don't feel anything. It doesn't hurt. It was absolutely super. The pain subsided after the first 7 days. By the time I had it taken off on the 12th day, it was much better. It would reduce so much that I could actually think of other things in my life. The painkillers actually, I reduced quite a lot. The Aramorph, I reduced to having it before I went to bed and first thing on the morning, and the rest of the time I just had an occasional paracetamol. And now I am just on a paracetamols about twice a day. I was in quite a bad way, and now I'm looking forward to being able to enjoy what I can with my life. I know that it helps enormously. I would like other people to have the same done to them.
So I just think that's just such an amazing story, and I would really like to say a huge thank you to June and all the team at Hearts One for allowing this video to be shared with everyone this evening, to enable us to have a real insight into the challenges of living with a painful leg ulcer and how AccelHeal has totally transformed her quality of life. And I actually heard from her clinician today, and apparently her wound is virtually healed. She's been fitted for a compression garment, and she's going off on her holiday to Mallorca in 2 weeks' time. And I'm almost tearful thinking about it. Thank you.
Thanks very much. That is fantastic. I think it's so powerful, isn't it, to hear the patient's story, because that's what it's about. And I think just looking at the polling at the beginning there, you know, people are struggling with managing wound pain for their patients. So if we can do something about it, it's really important. But we need to hear that patient story. You know, one of the questions that's just come in, just one of the recent ones now, is around, you know, how we can raise awareness of the importance of having an analgesia or a pain plan in place, because it often isn't done. A comment that, you know, GPs seem surprised that we need a plan in place. To both of you, really, you know, how can we improve just raising awareness and improve this situation, how we can make people understand that it's really important that this is in place. I don't know if you want to start, Liz, by answering that one.
Well, I think events like this and just spreading the word amongst clinicians, really, you know, and many of the clinicians who I'm working with and who've used the therapy, you know, I think most of them would join me to say that they can see the changes that it enables the patient to have. And obviously, you know, much more educational events like tonight's and some of the conferences, and look at some more of the literature about it. You know, it is out there now. There's lots of evidence there to support its use.
Thank you. What about yourself, Amelia? Obviously, your role in research. How do we spread the word? I mean, there's a lot of what you said today. I'm thinking, I didn't know that. So how do we get that out there to place an importance on it?
I think one of the ways that we can do it as nurses is by having a confidence in our own understanding of the situation and the confidence to advocate for that patient. I quite often find in all pain management situations that nurses are thwarted by when they get questioned about, what do you really think so? Is that really a problem? And I think it's having that confidence in the evidence and saying, well, actually, there's a lot of evidence for this. And not only that, but this individual patient here is a very important person. I think one of the things that really is compelling in terms of the evidence for me is the fact that this is cost-effective treatment. And I think if you can demonstrate to your commissioners, to your GPs, that actually this isn't just a wild stab in the dark, it's very likely to have a very significant impact on your patient, and it's financially worth pursuing this rather than struggling on and on and on with somebody whose quality of life is very limited and whose wound is not healing. I don't know if you find the same, Liz.
Yeah, absolutely. It is cost effective, and there's many cost effectiveness studies that have demonstrated the reduction in nursing time specifically, which is really the most expensive component of managing wounds. You know, if we're going to get these wounds healed faster, then obviously that's going to reduce. I mean, this lady's just a typical example. You know, her wound's now healed, 4 weeks, 5 weeks after starting the therapy. So, we can move patients along and get them back to their lives again, really, like June said.
Yeah, I mean, there's been comments there around wound types and wound chronicity and why maybe some people get pain, whether it's combination pain, whether it's just nociceptive or neuropathic. Is there any evidence as to nipping things in the bud early and managing pain earlier and more effectively? Does that have a better impact sort of for the future in terms of chronicity? Have you got any thoughts on that, Amelia?
There's a lot of work not in wounds, which suggests that early aggressive management is the better way to go. But I think that the problem with wounds is that that little internal environment is a little world of its own, and it's not pain that's driving chronicity so much as the actual, condition of the wound itself and the other factors necessary for healing. In terms of early pain for wounds, that can be beneficial because it can help people get up and about, and it can help people comply with treatment. So that's one of the reasons for early, aggressive early management of it, quite apart from it's a human thing to do. So one of the risk factors, I think, probably is that, and it's difficult to tell this from the research itself, but I strongly suspect that the longer a wound goes on, the more likely it is to become complicated in terms of the mix of pains, and the more likely you are to get difficult to manage neuropathic pain. And I think what we're not seeing differentiated in the electrical stimulation therapy research at the moment is whether electrical stimulation therapy is equally reducing neuropathic pain as it is nociceptive pain. And part of me thinks, does it really matter? Because it's actually reducing pain and it's getting rid of pain. So does it matter which pain it's getting rid of so much? But from a researcher perspective, I'm quite interested to see that.
Yeah.
There's been a couple of references to TENS machines, which can be more accessible. Are they the same thing? Are they different? Could you just clarify that point, because I think there's some confusion out there.
There's at least one study where they've used TENS pads on either side of a wound and produced some benefit, but actually there's not very much evidence of them being helpful. They're using a different range of currents, and they're producing a sensation as well, and a lot of patients would find that the sensation that accompanies a TENS machine across a wound bed, a sensitive wound bed, to be quite uncomfortable. So I think they have a very limited place, unfortunately, in the direct management of wounds. One of the things about devices like AccelHeal is they're sub-threshold. The patient's not feeling what's happening, and they're not having their pain aggravated by that altered sensation that the TENS machine would produce. So they are quite different. I'm not saying that TENS wouldn't be useful in pain management, but you wouldn't be using it near the wound.
No, thank you for that. There's some questions around contraindications. Liz, you know, when you were using it, were you sort of having to consider that? Are there times then you wouldn't want to use this technology?
So the main real contraindication is any suspicion of malignancy in the wound, particularly. And if the patient's got a wound near the chest and has a pacemaker, then obviously not to use it near that chest wound, but they can use it on a lower limb wound. The only other thing to consider is patients with epilepsy as well, not to use it near the head. Apart from that, really, I've used, you know, patients with diabetes and heart problems. You can use it in most comorbidities. And as I say, I've used it on a wide range of wound etiologies as well.
Okay. What about age? There's a question here about, can it be used for children who have wound pain?
There's actually no evidence for AccelHeal specifically on children, just because the research hasn't been done. But I know that there are some sort of planned thoughts around looking at that for children with, particularly with burns. So that's, you know, watch this space really. We need to consider that. But really, just because we don't know the effect on cells, you know.
Yeah, there's some comments here of people have been trialing electrical stimulation therapy on wounds, and how powerful the results have been in terms of, you know, they're predominantly have been using it to try and assist healing, but the impact on pain has been quite significant. You know, it's a bit like, I suppose the reference you made, Amelia, to compression, which obviously that's what we need to do. We need to get compression on if we're going to heal someone's venous leg ulcer. And we know that compression in isolation is anti-inflammatory and will reduce pain, but it's actually getting people to that point if they have a lot of pain. So I would imagine that a lot of work that's been done is associated with people who are not tolerating the compression, and then you get results. I suppose both of you have been involved in that sort of work.
Yeah, I mean, over the years I've been using it, you know, to facilitate either some form of compression or sort of patients moving them from reduced compression up to high compression if they've not been able to tolerate it. So absolutely, that's, you know, one area where it's been looked at and has been very successful.
But not only that, of course, because there's a lot of work going on in diabetic ulcers, etc. at the moment. And I think there is a question in the chat there about, would you use it on a closed wound for pain management? It's quite an interesting question, because it's predominantly designed as something to promote wound healing, and the pain relieving effect of it is probably secondary. But it for our purposes, they're both very important primary outcomes. So I can't imagine that I would necessarily be interested in it for a closed wound. But I think it's useful for a very wide type of range of wounds. And one of the things Liz was talking about there was where you wouldn't put the device, and that just reminded me of the old advice we used to be given about TENS machines, not to put them near pacemakers, and what have you. And I wonder a little bit more work could be done on that, perhaps, because with TENS machines, it's been shown that some of that advice is no longer necessary to follow. So I think we need to probe some of the contraindications as we get more used to these devices and start thinking about the contraindications even more.
Yeah, for sure. I have actually interestingly noted quite a lot of softening of scar tissue using not specifically just on a purely healed wound, but the scar tissue surrounding an actual wound where they've had maybe previous ulceration or pressure ulcers, softening of that tissue. And there was, some other clinicians have noted this as well, that it definitely has this cellular effect on softening the keratosis around the wound.
So that doesn't surprise me. So sorry,
No,
Sarah. I was reading some research about this today, that about the impact of wound chronicity on that scar, on the thickness of scar tissue and the lack of flexibility of the scar tissue. And the more rapidly and normally we can encourage a wound to heal, the less likely you are going to have that thickened scarring. And interestingly, high levels of opioid use are associated with quite thin epithelialization. But that's in animals. I don't know about in humans. So there's a lot to it. The more normal we can make it, the more likely that the tissues are going to heal in a pliable and useful state.
Yeah, I've used it for 3 venous leg ulcers that were recurrent, and they'd been recurrent despite compression, and they were recurring sort of every 3 to 5 months. And then we used it for these 3 patients, and there was no recurrence. I couldn't follow them up after a year, but they remained healed within a year. And one of the patients reported they felt the tissue was different. They felt it really healed, sort of the strength and the durability of the healed tissue was different. And they could have a hot shower, when you've sort of injured yourself and you can only tolerate warm water, they could actually have a hot shower for the first time. So, as you say, Amelia, there's a lot more work and a lot more.
Yeah, I think you're right. It's one of those areas of research that will go on, won't it? Just finally, because I'm aware we are sort of out of time, but I think it's what a lot of people might be thinking is around how do you get to the point of evaluating this and convincing those that hold the purse strings that this would be a good modality to invest in terms of procurement. Are there any sort of wise words to encourage people to go ahead with that?
Well, certainly the AccelHeal Technologies is very happy to support local evaluations. They're doing some ongoing, and that kind of implements then sort of a local evidence base together with all the larger evidence that we've got available. But then with that, obviously, sort of support looking at pathways. There's a few pathways being initiated now in the UK, and then with that, of course, formulary, adding it to the formulary, and just showing really the cost effectiveness, evidence that there is to support it as well. Not just
and the patient voice, maybe, if you've got stories like that as well, and it is the cost effectiveness and the quality of life, isn't it, as well?
Yeah, definitely.
Well, we could talk about this for another hour plus, I'm sure, but I'm aware of the time and I don't want to keep any of you any longer than we have to. But that was an absolutely fantastic session. I hope all of you out there have got a lot from this. I certainly have. Want to thank Amelia and Liz for contributing, and again to AccelHeal for sponsoring this event.